I'm going to talk through ABG interpretation. Just start. Okay, so why do we want to do an ABG? So it offers you immediate information about things like gas exchange, acid-base status, electrolytes, lactate, but it's very quick. So once you've taken your sample, you can run it straight on the ABG machine and you can get these quick values to work with. It's particularly important for gas exchange because if you're taking blood from from an artery as opposed to a vein, you'll get quite good information about oxygen levels and CO2 levels. And as a consequence of that, your acid-base status, I guess, is a little bit more reliable in that sense. Electrolytes, they're not always reliable, but it's good to get an immediate reading. Often to get a more reliable reading, you'll need to send them off to the lab like you would do with any other blood test. And in the emergency setting, things like lactate, again, very important. So these are the things that I do to just do a quick assessment of acid-base status. So first I think about the clinical picture. So are they on oxygen? Are they deteriorating? What's sort of going on with them at the minute? Then I go on to step 1. So what's the pH? pH is generally controlled closely at sort of 7.35 to 7.45, and that works through either buffers or excretion of acid. So we've got buffers like bicarbonate and proteins in the blood. And then we've also got hydrogen ions being excreted by the kidney and carbon dioxide excreted by the lung. So there are a couple of different components to pH. You can get a rapid change in pH with ventilation. So if your CO2 level in your blood increases significantly, then your pH will drop. So but that's a very quick change because it's to do with ventilation. Then we've got PCO2. So what's the PCO2? So that's partial pressure of carbon dioxide, and that just gives you a sort of an estimate as to how much carbon dioxide is in your blood at that point in time. And similarly, you can also you also get a reading for partial pressure of oxygen. So that will tell you how well oxygenated the patient is. Then I go on to think about step 3, which is what is the bicarb level? And the bicarbonate is produced by kidneys and again acts as a buffer. So a high bicarb level will bring down your pH, whereas a low bicarb level will increase your pH. And then step 4, are there any other signs of compensation? And I'll talk more about compensation later, but that's just something else to think about. And that is an assessment of your acid-base status. If you want to look at sort of gas exchange, then obviously partial pressure of oxygen will also play a role in this. But I think all the other bits and pieces like base excess, lactate, electrolytes, glucose, in terms of finals, I don't think they'll play a massive role, but I did want to mention them anyway. So base excess is the amount of strong acid which would be needed, base excess is the amount of strong acid which would be needed to be added or subtracted from a substance in order to return the pH to normal. So it's the amount of extra acid that you need to add to get the pH back to normal. So your normal range for base excess is -2 to +2. And if you've got, it sort of just reflects the metabolic component of any acidosis or alkalosis, and it doesn't really reflect the respiratory component of that. Then we've got lactate. So we've already spoken about lactate, but it's essentially just a byproduct of anaerobic respiration, and it will increase when you sort of get your tissue to when you get body tissue to use anaerobic respiration. So things like sepsis or shock, you might see lactate rising. Electrolytes, I've already mentioned, but they're not particularly reliable with an ABG, but it's nice to get something quick and just have a quick assessment of what's going on. And glucose level. Obviously, we all know that you can get glucose level with capillary blood gases anyway, so that's nice and quick, but it's just something else that will come out on your ABG reading. So we'll look more into the steps. So this is, again, assessing your acid-base status. So I'll talk through all the different bits. So if your pH is increased, then we're thinking about alkalosis. If your PCO2 is either normal or raised, that doesn't quite fit with alkalosis. So we'll move on and look at the bicarb level. And if your bicarb level is raised, then you're thinking metabolic alkalosis. Similarly, pH level is raised, but your PCO2 is decreased. And we know that if CO2 levels are high in the blood, then you're acidic. And given that your PCO2 is decreased, then that's a sort of a cause for why your pH is high. And that you would call respiratory alkalosis. And then we'll go on to when your pH is low. So when your pH is low, that's acidosis. We'll go on to look at PCO2. So like I said, if you've got high levels of CO2 in your blood, then you're acidotic. So that would give you an explanation for why you've got this acidosis. So that'd be respiratory acidosis. But if your PCO2 is either normal or low, that wouldn't really offer an explanation for why your pH is low. So you go on to look at your bicarb level, and if your bicarb is low, that offers you that explanation. So that's metabolic acidosis. So yeah, I think the sort of easiest way to think about it is just pH, then PCO2, then bicarb, and just look for a reason as to why the alkalosis or the acidosis is happening. And I think just remember CO2, if it dissolves in blood, is acidotic and it's going to bring your pH down. And if your bicarb is high, it's going to bring your pH up because it's alkalotic. So these are the two components that are working together to maintain your pH level in your blood. And CO2 is controlled by how fast you breathe, if you're breathing it out or if you're sort of retaining CO2. And then your bicarb level, it's managed more by your kidneys, so it's a much slower process. But that's where your bicarb's coming from. And then we can go on to think about compensation. So like I said, pH is your first step, and then you go on to look at PCO2, then bicarb level, and then compensation. So compensation is what your body does to sort of manage the acid-base disturbance as a result of, say, respiratory alkalosis or metabolic acidosis, something that your body does to bring its pH back down to a normal level. So if you've got metabolic acid alkalosis, your pH is high, your bicarb level is high, and the only thing the body can then do quickly to respond to that is sort of alter the carbon dioxide level. As I said, the carbon dioxide is it will bring your pH down. So what your body will do to compensate for that is increase your PCO2 and try and get your pH within the normal range. If the pH doesn't come back into normal range, that's called partial compensation, where you see that the PCO2 is rising, you see that the body's trying to compensate, but it doesn't quite bring your pH back to normal level. So that's partial compensation. But if it does manage to bring your pH into normal levels, then that's complete compensation. Respiratory alkalosis, the compensation for that would be a drop in your bicarb level. Like I said, CO2, you can sort of breathe it off very quickly, but bicarb is generated by kidneys. So if you're generating bicarb, then it's going to take a little bit of time. I think the arrows are upside down for the second box there. I don't think it's completely uploaded, but just so you're aware, respiratory acidosis, if you're retaining CO2, you're acidotic, then what your body does to compensate for that is increase bicarb production. So the arrow is upside down for that. So your kidneys generate more bicarb to act as a buffer and bring your pH back down into normal limits. And then metabolic acidosis. So that's when your bicarb level is too low, and that's what's causing your acidosis. And your body compensates by blowing off CO2. Again, arrows upside down for this, sorry about that. So your body's blowing off the CO2, and that should hopefully sort of counteract the acidosis a little bit. And if it's partial, it will bring your pH back down into the normal range. But if it's if it's partial, then your pH won't be in the normal range. But if it's complete compensation, then your pH will come back down into the normal range. So important things to remember for this is compensation can either be carbon dioxide or bicarb. If it's carbon dioxide, it's very quick. If it's bicarb, often takes a little bit of time. And partial compensation, your pH remains sort of deranged a little bit, but complete compensation, your pH will come back down into your appropriate levels. And then gas exchange is another important thing that I mentioned at the beginning. So there are two types of respiratory failures that you would see on gas exchange, on ABG. So type 1 respiratory failure. Type 1 respiratory failure involves low oxygen, but normal or low carbon dioxide levels. So you're not retaining CO2 when you've got type 1 respiratory failure. It's because you get damage to lung tissue, and as a result of that, you don't oxygenate enough, but there's enough functioning lung tissue to excrete CO2. So you drop oxygen levels, but your CO2 is still fine. And you see that for different types of things, but I think probably the most important one on that list is ventilation perfusion mismatch, so VQ mismatch. So things like PE or pneumonia will often increase your oxygen requirements. So when you do an ABG, you'll see that the PO2 is quite low, but they don't affect your CO2 levels in the same way. But other things like emphysema, pulmonary edema, or if you're at high altitude levels where the oxygen you're breathing in, the air you're breathing in has low amounts of oxygen, you'll get the same sort of effect. Then type 2 respiratory failure is when alveolar ventilation is insufficient to excrete the carbon dioxide that's being produced. So you start retaining carbon dioxide, and as a result of that, your pH levels will drop as well, so you'll become acidotic. Different things again can cause that, but if you sort of wanted to group it into different things, so either it could be fatigue complicating a type 1 respiratory failure. So if you've got type 1 respiratory failure and you're getting quite tired, you're not able to ventilate well enough, then your alveolar ventilation is not sufficient to excrete that CO2 that you're producing. So then you get a buildup of CO2. It can also be due to abnormalities in the thoracic cage. So if the thoracic cage itself is preventing adequate ventilation, so things like severe kyphoscoliosis or obesity, hyperventilation syndrome, they can do the same thing. And then neuromuscular weakness as well. So things like MND or myasthenia gravis, they can tire you out, so you're not ventilating well enough to get rid of that CO2. And another way to do that would be reduced central control of respiration. So things like opiates or brainstem dysfunction can cause you to tire, can cause you to not adequately ventilate. So things to remember here are type 1 respiratory failure, you're only affecting your oxygen levels, but CO2 is fine. Type 2 respiratory failure, both oxygen's decreased and you're starting to retain CO2. So just we'll move on to a couple of questions. So this is the ABG, and I think I'll flick onto the next page and we'll see what answers everyone's sort of giving. And I think this is where Menti comes into play. So we've got a 33-year-old pregnant lady presenting with leg swelling and shortness of breath. Her ABG is as follows. So I just want you to have just a moment to read through the ABG and think about what the ABG shows. I think if I flick onto the next page, it should give you options for answers. Is that right, Danielle? Or do they already have access to the answers at the minute?
Yeah, if you click onto the next page, then everyone should be able to submit their answers. And if they click show more information on their phone, they'll be able to see the ABG results again.
Okay, perfect. So fine. So I'll click onto the next page so that you can start putting in your answers. All right, that looks really good. So yeah, we'll just talk through the the ABG then. So with this ABG, you've got someone that's got a normal pH. Your PCO2 is also normal. So nothing's acid-base wise, there's no real disturbance there, but your PO2 is low. So that means they're not adequately oxygenating, and bicarb is also fine. So this would be in keeping with type 1 respiratory failure. It's just low oxygen and no acid-base disturbance. Often in this kind of scenario, if you're breathing quite fast, you can blow off a lot of CO2 and you can become alkalotic. And as a result of that, you can have some acid-base changes. But for the first question, I just thought I'd keep it nice and simple. So yeah, that's the right answer. So well done. And then the next question, what do you think the most likely diagnosis is? I think this is a free text question. So just put in what you think. Yeah, well done. So nice barn door presentation. Yeah, so leg swelling, what I was going forward there was TBT and shortness of breath, PE, and with a pregnant lady, it's just a predisposing factor. And as I said, often with PE, you will also get respiratory alkalosis because you're breathing so fast and you're blowing off that CO2. And as a result of that, that's another change you'd see. But again, like I said, just kept it simple for the first question. All right. Next question. So you assess a 72-year-old man with an extensive smoking history and long-term shortness of breath. Just give you a moment to look through the ABG, and I'll flick to the next slide that will give you an option to answer. All right, so yeah, well done. So you've got someone who's 72, extensive smoking history, long-term shortness of breath. So you're thinking they've already damaged the lungs. pH is low. The pH is within normal limits. So acid-base wise, something might be happening, but it's not affecting their pH. PCO2 is high, so they're retaining CO2, but pH hasn't been disturbed in this, so that's important to remember. And PO2 is low, so they're in type 2 respiratory failure in that their PO2 is low, so they're not oxygenating well, but they're also retaining CO2. And bicarb level is high, so at 31. So with bicarb level being that high, you know that it's a chronic change and the pH is also fine and within normal limits. So with this, you can sort of safely say that there's respiratory acidosis that isn't actually acidosis because the bicarb is increased enough to compensate for that. So that's complete metabolic compensation. So respiratory acidosis with complete metabolic compensation. And what do you think the most likely diagnosis here is? So 72-year-old man, extensive smoking history, long-term shortness of breath, respiratory acidosis with complete metabolic compensation. Yeah, nice and easy. All right, well done. And one last question. So 21-year-old with polyuria, polydipsia, and nausea. Just give you a moment to look through the ABG, and just so you remember, base excess is the amount of strong acid which you need to add to get the pH back to normal, and that reflects the metabolic component. So I'll click on to the next question, next slide. All right, so I'll show you the right answer in this. Just to go over this one real quick, because I think a couple of people understood that it was partial, but respiratory and metabolic have been mixed around. So you've got the pH disturbance, so you're acidotic at 7.26. Then you need to find a cause for the acidosis. go on and look at PCO2. In this case, PCO2 is low, and that wouldn't then be in keeping with acidosis. You'd have to have high PCO2 to have respiratory acidosis. PO2 is fine. And then you go on to look at bicarb level. So bicarb is low, and you know that bicarb acts as a base. So if it's low, then you're thinking, oh, that could be a contributing factor to acidosis. And that would be in keeping with metabolic acidosis. And the base excess kind of confirms that because it's -11. And your PCO2 is low. So it's an attempt for the body to kind of bring your pH back into normal range. So that would be metabolic acidosis with partial respiratory compensation because your pH is still deranged, but your PCO2 is sort of making an effort to bring that pH back. So what do you think the most likely diagnosis in this instance is? Yeah, cool. Again, nice and sort of barn door presentation. So polyuria, polydipsia, nausea, vomiting, and then you get the metabolic acidosis as well. With the low CO2, it's something that you might see with so they're just sort of trying to blow off that CO2, and it's called Kussmaul breathing. I'm sure you've come across it. Just an attempt to sort of compensate for the metabolic acidosis. So you're just blowing that off and trying to bring your pH back into normal range. Again, like I said, partial compensation because your pH is still quite deranged. All right, I hope this has been helpful. Has anyone got any questions at all?
I'm just having a bit of a look on our Q&A function to whether we have any. If you have any further questions, anyone else in the audience, and you want to submit them, please click on the Q&A function at the bottom of your screen, and you should be able to ask a question in there, and I'll be able to read them out now. So we've got one, which is, how is it important clinically to differentiate between type 1 and type 2 respiratory failures?
Okay, so with type 1 respiratory failure, obviously your oxygen levels decreased, so you can give them some oxygen. With type 2 respiratory failure, if they're starting to retain CO2, you need to think about how you're going to give them the oxygen. So retaining CO2 is quite harmful to the body. And often if you just give them increasing sort of concentrations of CO2, it's not really going to do anything other than suppress their respiratory drive, and you just get them to increase the levels of CO2, and that has harmful effects. What I mean by suppressing respiratory drive is that people with things like COPD are kind of reliant on oxygen concentrations for their respiratory drive. So if you're increasing it massively, then they'll they'll breathe even slower and start to retain even more CO2. So it's important to titrate your oxygen target saturations according to whether or not they're retaining CO2. So if they're not retaining CO2, often your target saturations are between something like 94 and 98%. If they are retaining CO2, then you bring that down to 88 to 92% in an effort to preserve their respiratory drive and make sure that they don't end up retaining a lot of CO2.
Right, we've got a few more questions have just come through in a bit of a bundle. So we've got, how do we see mixed acidosis and alkalosis? I can't tell whether that means why would we see it or what would it look like, but
I'm not sure. I think so. I like to keep it simple. So if your pH is deranged, then I'm going to say that you're either acidotic or alkalotic. If you're within range and both your CO2 and bicarb level have changed, then you know that something is contributing to the acid-base disturbance, but it's been compensated for because your pH is okay. And I think that's probably as much as I can offer on that, but I'm not sure.
Okay. We've got, can you explain what base excess is again, please?
Yeah, of course.
Mihan.
Yes, of course. So base excess is defined as the amount of strong acid that you need to add to return the pH back to normal. So if you've got a positive base excess, and that indicates the amount of acid you need to add to get the pH back to normal, that means that you're alkalotic and you need to add that much extra acid to bring your pH back down, and vice versa. So if your base excess is low, then that indicates that the sort of converse, I guess, the amount of extra base you need to add rather than acid to get the pH back to normal range. It's really, at the level that we were working at medical school, I didn't really find it massively helpful, but it is just a reflection of the metabolic component of your acidosis or alkalosis. I found that it was useful for things like ALS, and I think that's when I started appreciating it more. But in terms of the questions that might come up in finals, I think, to be honest, bicarb offers as much as the base excess would offer anyway. But yeah, so base excess is the amount of acid you need to add. Positive means a lot of acid needs to be added to get the pH back to normal. Negative means a lot of base needs to be added to get the pH back to normal.
Okay, brilliant. Thank you. We have another question, which is, if you have a fully compensated picture, e.g. metabolic acidosis with full respiratory compensation, how can you tell what it is aside from the clinical picture?
So if you've got a fully compensated picture, then like the example earlier with the COPD, go back to it. With the COPD, so even though it's completely compensated, you can see that there's some sort of acid-base disturbance where the bicarb is really high, you're still retaining CO2, but your pH is in normal range. So you can see these different processes going on behind the pH. So even though pH is normal, there are a couple of things that are happening. So you can kind of see what's contributing to it. So we know with the clinical picture here, plus the fact that they're retaining CO2, that it's probably going to be COPD. And then with your bicarb level being deranged, you know that it's a chronic process. So even though it's complete compensation, it doesn't mean that there isn't more information available with your ABG. And it can be the same with sort of metabolic acidosis. So you can have complete compensation because of your CO2 being blown off. So it still offers you a lot.
Okay.
Sorry, I hope that was what they were trying to ask.
Yeah, I wasn't quite sure either, but I think you covered it. I've got one more question that I've got here, but if anyone else has one, please put it in the Q&A section, because we are actually running a little bit ahead of time, which is amazing, very efficient. So I've got the question, why is metabolic compensation so slow and respiratory compensation fast?
Okay, so respiratory compensation is to do with how you control your CO2 levels. So as I said, if CO2 levels in your blood are high, then you're quite acidotic. If CO2 levels in your blood are low, then you're alkalotic. CO2 is because it's controlled by ventilation. So if you breathe really fast, then you blow off that CO2 nice and quickly, and you become more alkalotic. But if you're not breathing very quickly and you're not ventilating well, then you retain the CO2 and you become acidotic. So because you can control ventilation very easily, and CO2 dissolves quite easily as well into your blood, you can control that very quickly. So respiratory compensation can be quite quick as a result of ventilation. Bicarb, because it's controlled by the kidney, so that includes production and excretion, it's quite a slow process. So you need to be able to filter out all of the bicarb in your blood and kind of excrete it out, or produce more bicarb, and that can take some time. It's not that it will take sort of weeks, but it's just with CO2, because you can just control it by breathing quickly or breathing slowly, respiratory compensation is a lot quicker. And I think with things like, so if you can, with hyperventilation, so if you've got, with anxiety, you can start to sort of hyperventilate, anxiety or fevers, you can start to hyperventilate. And when you hyperventilate, you blow off that CO2 very quickly and very, because it's just such a quick process, you can derange your pH as a result of that. So purely because CO2 is controlled by ventilation, it's a quick process. Bicarb is controlled by your kidneys, and because it's to do with excretion and production, it can take a little bit more time. So you know when your bicarb is deranged that it's a chronic process.
Real, and I think we've got one more question and then we'll move on to our next talk. So someone's asked, can you give a short summary which can be used to explain to the general public? I don't know whether that's explaining what an ABG is.
Yeah. Okay, so ABGs are blood samples that you get from your arteries rather than your veins. The reason why we do that mostly is because arterial samples are a better reflection of gas exchange. So because they haven't gone through your body system and your body hasn't used the oxygen and secreted and made more carbon dioxide, you can get a very quick representation of how well you're taking in CO2 and breathing out CO2 and oxygenating. So really it's most crucial for gas exchange. With things like acid base, so because you're also taking a quick sample from your artery and you're analysing it so quickly, you can get a very quick understanding of whether you're acidotic, alkalotic, what's happening with your bicarb levels. So sorry, I know I slipped off, it's not for the general public anymore, but yes, it's just a very quick representation of how well you're absorbing oxygen, how well you're getting rid of carbon dioxide from your body, and also a quick understanding of how well, of whether or not you're controlling the pH level of your blood. So whether it's a bit too acidotic, if it's a bit too alkalotic, you can get an understanding of that.